Thank you so much for the wonderful introduction. Thank you for being here on a Monday night. It's my first proper time in Hong Kong, and I appreciate the traffic here. I've got to stop complaining about my traffic at home. You've got the real ones here. So I'm so delighted to be here tonight, and thank you for allowing me to share some of my experiences with you, and hopefully we can take something away. I'm most happy to answer any questions. So I think as an introduction, I want to just take a moment to appreciate how far things have come. And just like cataract surgery, it's not really that long ago when, we don't really put lenses in, large incisions, and then when phacoemulsification came in, there was a huge resistance in taking on new technology because it's something we're so familiar with. And so early on, there were a group of surgeons who were against it, but really, if we start challenging some traditions, things will evolve. And if we think about what we have today, we really appreciate those ahead of us who are able to challenge the traditions and allow us to evolve over time. To the point now, not only phacoemulsification has evolved tremendously over time, but think about the intraocular lens that are available to us, going from a single lens to now multifocals and various different technology. So keeping that in mind, thinking about glaucoma, this has been our traditional treatment paradigm for a very long time. So often if you diagnose the patients, you start with medications because it feels safe, and then you may go on to laser if they can't tolerate them. And if they're still progressing, then you consider filtration surgery. And these are relatively invasive surgeries. Following that, you have tube and possibly cyclodestructive procedures. However, I think if you've seen enough glaucoma patients, you'll know that drops are not risk-free. So there's allergies, periorbital severe dry eyes, and I think especially nowadays in our modern lives, dry is very common anyway. With all the computer and screen use, but it gets worse. I've seen patients with keratitis from toxicity as well, and not only that, but socially, all the redness, etc. On the other hand, traditional surgery is not risk-free either. They're high-risk procedures. You can get infections, hypotony, sometimes extrusions, leaks, bleeding, and hence there's resistance to go straight from drops to major surgery. So the evolution of MIGS has really come along to bridge this gap. It's less invasive, with a better safety profile, much better recovery for the patients. They do work, they do reduce intraocular pressure, and they can reduce the number of medications as well as side effects. So as a result of that, due to its availability, this concept of interventional glaucoma or contemporary, whichever way you name it, has come about. It really just allows us to be more proactive with our patient treatments rather than being reactive. So rather than wait until it's quite bad, you have no choice, we can actually offer them something early on. And that's the way we challenge the current standard of care. With that, think about the 2025 and 2026 treatment paradigm. Maybe, just maybe in your own algorithm, everybody's different, but perhaps medication does have a role, but not always necessarily the first line. With the LIGHT study from the UK, I'm sure you're aware of that, has shown to be an excellent, SLT showed to be an excellent first-line procedure for some of the patients with treatment-naive eyes. And then you have the MIGS that's being introduced, gives you another option, and there's also minimally invasive leg surgery, such as Presiflow and ZenStent. Following that, of course, you still have the traditional surgery, such as trabeculectomy and tube surgery, as well as cyclodestructive surgery. And not only that, you also now have micropulse cyclodiode available that you could perhaps use a bit earlier. As such, maybe medications is used as a bridging gap between all these procedures. So with that introduction, I'm just going to give you an overview of what we're going to talk about today. Firstly, what is MIGS? I understand there's a range of experience with MIGS in this room. I would like to take the opportunity to introduce you to iStent Infinite. And then discuss why should we be bothered with MIGS and iStent Infinite. As door technologies is not going to be embraced straight away, but perhaps we can open the forum to discussing maybe there's a role for MIGS. Who are the best candidates and how to achieve the best outcome. Along with that, give you some surgical pills on how to get started and how to manage some of the complications. I'm going to finish off with some case studies and have an open discussion about when should we start intervening in these cases. So firstly, what is MIGS? It's basically a procedure, minimally invasive glaucoma surgery, that's predominantly a trabecular meshwork bypass. So your normal aqueous outflow, as you know, goes from the anterior chamber to trabecular meshwork, Schrems canal, and collector channel. So the iStent series was one of the first ones that came out with multiple different generations over time. And the goal is to bypass any blockage in the TM and provide a direct pathway to Schrems canal and collector channel. And over time, obviously several generations has passed, and now iStent Infinite has come about, which includes 3 stents. So you can see there's 1 stent, 2 stents, a different flange, and then iStent has a 3 stent with infinite firing in the injector. This is just an animation of the iStent inject. It's made out of titanium, it's heparin coated, it's about 360 microns in height and diameter. It's safe to use at MRI, so most of the patients will ask you that question. So make an incision as you normally would. You'll direct it to one area first. As you can see, you have a guide in the center, the trocar, that allows you to place it into the TM. So you really want to aim at the trabecular meshwork, not above or below, and avoid the ciliary body, because sometimes it can be quite confusing. And you want to space them out as far as possible and make sure you realign that collector before you remove from the eye. And this allows you to drain this towards a collector channel. So the second question, I guess, is why should we be involved with MIGS and iStents? Quite often the patients will say, well, drops are pretty safe, isn't it, doctor? Why should I do that? Well, we know that intraocular pressure control only works if the patient is actually taking the eye drops. I'm not sure about your experience, but in my practice I know that compliance is quite variable. If the patient fills the script but they leave the drops there, or they have side effects to stop the drops, it's not going to work. Whereas you have MIGS or even SLT, you have 24 hours continuous stable intraocular pressure. Adherence, like I said, is very important and it's not really required for MIGS. Ocular surface is a big one. Obviously, the longer you use drops, it can cause ocular surface disease, dries, and I see that a lot in my practice. Whereas the MIGS obviously preserves ocular surface with less inflammation. Safety profile, obviously drops, is non-invasive, easy to start with, but MIGS is also quite safe. It is obviously a surgical procedure, but a minimally invasive, less risk of hypotony and leg issues compared to traditional surgery. Quality of life is very important. You know, with the topical drops, I found like my patients travel, they often have issues with traveling and temperature variations, whereas the drop-free convenience with MIGS. Cost-wise, there's more upfront cost with MIGS, but in long term, if you can reduce the medication burden and improve quality of life, and hopefully with better procedures and techniques, maybe it'll be more cost-effective in the long run. In terms of impact on the future, I found that if you can reduce any ocular surface inflammation, in fact, the patients will do better if one day they do need any conj-based surgery or filtration surgery. So there are some key trials that support iStents. I mean, early on, there's only a few, but now there's an explosion of studies. But we know in 2011 there was the first major safety profile, a landmark study, that looked at stents with phaco, it's a combination surgery, versus phaco alone. And it showed that more than 20% drop in IOP was achievable and about 66% versus approximately 50%. And it showed that it was relatively effective. And that was with the early stents. Then the pivotal trial came on in 2019 that looked at Standalone versus combination in mild to moderate open-angle glaucoma and showed an improvement in the efficacy, up to about almost 76% compared to about 62% in the phaco group. And they also looked at quality of life and improvement in quality of life in the same group of patients. Then if you look at real-world studies, there's a 5-year retrospective observational study, and they looked at, there's about 6 to 10 millimeters of mercury drop in intraocular pressures and also a reduction in medications. And that was sustainable. I guess a lot of the questions will be like, if you remove cataracts, you can reduce pressure, but if you combine phaco with MIGS, you're probably more likely to have sustained reduction in pressure. Following that, we had a 7-year study, also showed fairly similar results, and the real-world 3-year multi-center study. And then the latest one, the integrity trial that compares head-to-head the iStent inject versus the Hydrus. And so far they've reported 6 months results, and already shown some results there, but we need to wait for the long-term study with that one. So then moving on, who are the best candidates? How do we know who we can offer this procedure to? I think if you're early on and in your experience with this, it's best to choose mild to moderate open-angle glaucoma so that you're not making it more difficult for yourself. Another category is the ocular hypertension patients. Perhaps they needed medications but become medication intolerant. I found that secondary open-angle glaucoma such as pigmentary dispersion, pseudoexfoliation, steroid-induced glaucoma can work quite well as well, especially if the pathology involves TM dysfunction. There's another group of patients, I had a conversation earlier about what type of patients you see here in Hong Kong. And I understand, in my practice I have one that's predominantly Asian, and the other one's predominantly Caucasian. So I definitely see a range of patients. And Asian patients, probably for cultural reasons, they're very reluctant to go ahead with surgery until it's extremely late. Unfortunately, sometimes it makes it even more difficult. So I guess, can we use these advanced cases? The answer is probably debatable between different groups of surgeons, and I have this debate with my colleagues all the time. I think more and more now we are accepting that we might be able to use these advanced cases, especially elderly patients who are not suitable for left surgery, but you need to buy them some time. It's not your ideal patient, but potentially that's a group you could use it in. But you need to keep in mind that you may not get sufficient IOP drop. If you're looking for single digit in this group, it's not going to happen. And you need to explain that to the patient. And most likely they will spell medications, and you do have variability, but you can consider it. The contraindication, I'll definitely advise you not to use in this group is neovascular glaucoma and uveitic glaucoma for obvious reasons. So angle anatomy is important. You want to make sure you don't know all the patients before you consider surgery. Obviously open angles with good visibility of the TM, minimal PAS is important. Poor predictors, so those on narrow angles, especially those on extensive PAS or scarring. The angle closure patients who've not had lens surgery or previous PI, I don't think they're great candidates, but if you are doing combined surgery or if the angles are open after, you can still use them in that group. Looking at other values, looking at baseline intraocular pressures, if they have higher baseline intraocular pressures, they're more likely to experience greater IOP lowering. If your target intraocular pressure is not extremely low, so you're looking for moderate IOP lowering, so the target is somewhere around 15 or above, then this may be a good option for you. But if your target is less than 12 or 10, standalone MIGS is less likely to succeed without additional procedures or medications. Based on medication numbers, the more that you're on, the more likely you can reduce the medication burden, not zero, but reduce the medication burden. Another group of patients, obviously ocular surface with medication intolerance, we mentioned that before, ocular hypertension patients, etc., and they have really poor tolerance to medications, toxicity, allergies, etc., they will experience a greater quality of life, even if they had modest IOP reduction. And that, to them, might be the most valuable thing. So moving on, how to achieve the best outcome. Like all procedures, TRABs, tubes, vitreoretinal surgery, cataract surgery, prior planning is crucial to avoid complications. And this, as most of glaucoma surgeries, blood is the enemy, especially standalone phakic patients. You want to avoid traumatizing the lens and causing a cataract. You want to minimize inflammation and bleeding. It's not always required, but if there are a lot of medications in prostaglandin and a lot, I may consider stopping them and using temporary oral acetazolamide about a week prior. Sometimes I may even use fluoromethanol a week prior to reduce the inflammation of the ocular surface, as I would for filtration surgery. If they're on anticoagulants, for example, you might want to consider negotiating with their physicians to avoid excessive bleeding. I found that in my Chinese patients, if they're taking herbs or fish oil, which they commonly do and they don't consider as medications, I was specifically asked to stop that 1 to 2 weeks before because they can actually bleed and they don't actually know what they're taking sometimes. And often it's to improve their blood flow, so in fact they bleed a lot more. On the day of surgery, I carefully plan anesthetics, especially patients with sleep apnea. I see in Hong Kong, I walk around, people here are very, very thin. In Australia, we're big people. So you may not have this problem, but I constantly have issues with big patients coming in with sleep apnea. So I actually use the intraoperative oxygen high flow, it's called. So it's like a CPAP machine on the table. Otherwise, they have this huge posterior pressure coming forward. If they're quite inflamed, you could use preoperative iodine or apoconidine or brimonidine at a second phase. That can actually cause vasoconstriction and reduce vessels. I use it a lot in my corneal practice, and I can use this in my glaucoma practice as well. Position is everything. Just like in property, location, location, location. So for eyes, it's position, position, position. You want to tilt the microscope 30 to 45 degrees away from you and towards you, and then tilt the patient's head 30 degrees away from you. And the biggest tip that I received when I first started, that worked very well for me over the years, is that if you're not sure what sort of view you want, if you just get to the point where you can't see the temporal iris, that's a great way to start. If you're in that position, invariably you put the gonier on, the view is good. And you want to pick a gonier prism that suits you, depending on your hospital. I have had experience with the Ocular Hill, but most recently I much prefer the Glaukos eye prism because you get a much better, wider view of the angle, and I don't need to rotate it so much. I found that the gonier prisms that has like a Thornton ring or a ring stabilization of the eye is actually much harder and actually cause pivoting issues. This will just give you an idea of the iStent Infinite. Looking at the anatomy, you have the introducer, which is a retractable silicone sleeve, and you have a singulator button, which is purple, and then you have the delivery button, which is black. And so the difference between this and the old one is that you need to load, because it's infinite firing. You can keep pressing the black button to fire, but you need to load each time. And when I first started, that was the one thing I've got to stop myself and think, you need to load. Or if you want to reload, so you say you fired the first one and you need to refeed it, obviously don't load the second one. You've got to go back in and make sure that's all in before you load the second one. And we can show that in the video later. This is just to demonstrate in real life. You can get it done under 3 minutes. You can. In my theatre, I love classical music, so I get the nurses to rotate the microscope. For me, you can see the microscope view and the external view. Once it's done, then you rotate the patient's head away from you, about 30 degrees. If the patient has trouble with their neck, you can sometimes put cushion behind the shoulders and rotate them away. I get the assistant to place the OBD on the top, so I'm all ready to go with my prism. With my injector, and make sure you want to gently place the prism on and avoid downward pressure, otherwise you get striation. So I look for pigmented TM, and I usually try and aim infranasal first, because that's most of the collector channels. I place the first one, so it's off to the side, and if I can quickly, you can hear the click, that's the loading, and that's the insertion. I go 2, and the blood reflux is actually a good sign it's in the right place. So we know blood is in anyway, it also tells us in the right place. You want to check the position, so I go back with the viscoelastics, double check. Because sometimes when you go back in, they're actually not in. Before I then rotate my microscope to the opposite angle, so typically superiorly is my last one. And I have the system ready to go again. And she'll pass me the prism and the injector and iStent. She'll place it over on the cornea again. allows me to go straight onto it with my gonio lens. I know exactly where I want to, you hear that, the click? So that was the scintillator, that's a purple scintillator. And I want to place it as far as my wrist can rotate. I go superiorly. And again, I want to double check that position before I exit the eye or completely. So the third stent often is the one that kind of like, you just leave and you come out and you have to be careful that you double check that before you leave. Normally I'm quite happy, but because I know it's presenting, so I do a final view of checking. You can see the 3 points. I'm happy that they're all there. Then you can see the IA part. You can see the episcleral vessels nasally. As you go in, just watch the nasal and infranasal. See the plunge of the vessels. Okay, so that tells me the flow is already occurring through the stents. So now you can compare. You see that on the left is before the IA. On the left, you see the plunge of the vessels. Predominantly nasally and infranasal. As you know, collector channel is mostly there. So that's a good sign if you want to check if that's working for you. So my tip now, before your first case, is practice gonioscopy on a couple of phaco cases beforehand. So you're not doing the actual stenting, just at the end of your phaco, just ask nurses to give you the prism and rotate, position the heads, and check that we don't see the temporal iris, and just practice a gonio view. You need to know exactly where you're going before you insert. Obviously, you need to be aware of TM and the ciliary body. They're different. If they're lightly pigmented, I think maybe not this population, I'm not sure, Prof, but you can enlighten me later. But in my Caucasian population, they're so light, sometimes you just don't see it. And so you mistakenly put in the ciliary body. If it's a standalone case, use marker or Marstat to constrict the pupil to help to improve the view and obviously protect the lens as well. Plenty of visco dispersive OVD on the cornea, or you can just use OVD that you have, and light touch and gonio prism to avoid this sort of corneal striation. Obviously avoid blood. When you're first starting out, avoid the limbal vessels. So if you make an incision, maybe go slightly corneal, and you can use bromocriptine or albumin for vasoconstriction. Now, if you go in and you can't actually see the TM or Schemm's canal, you might be overinflated. So quite often here early on, you can be a little bit nervous, and I did that for sure. I want to make sure it's all formed, but in fact, I realized I insert too much OVD, it's all tense, and then it actually blocks the blood flow into the Schemm's canal. So at that point, let some OVD out or visco elastics out, let it go hypotenuse for a minute. You can actually see the blood coming back, and then you know in the TM. You want to maximize the efficiency of your stent. So I encourage you to look for areas of pigmentation. So I found that if you have patchy pigmentation, that actually tells you that's where most of the collector channel is, and aim for that. Blood reflux obviously helps you to identify you in the right place, and you want to space it out as far as possible with a two-part technique, as we discussed. Now, in the MIGS, so I noticed, with the Asian patient, you either have very small eyes and angle closure or very big eyes with high MIGS. And those ones, sometimes you have this very soft cornea and cause corneal striation as you place a prism down. So when you place it on, if you do see striation, it's best to just relax, take a moment to breathe and relax, and actually lift up the gonio prism instead. That can actually preserve the view. So what about learning curves and how to manage potential complications? This is spacing. So if I look back at, I video my cases, and I look back to early on iStent second generation, see how close they are. So early on, I thought, oh, that's great, they're in. But in fact, I now look back and think that wasn't the right thing to do. Because early on, straight in, bang, bang, you are out. So then I looked at my sort of second generation when I had a bit more practice. I made sure it's spaced further away by rotating the wrist. So at that point, we haven't done the two-part technique, but you can see that's already a little bit wider. So now even wider now, when we started out with the, one, and then rotating your microscope to go as far as possible, I noticed my results had improved from then onwards. And that's only with the 2 stent, and now obviously with 3 stent, we really have to think about it and move it as far as possible. So So this I really rotate, and I do have a very flexible wrist, so I go as far as I can see, obviously within view as well. This is just a reloading, and so I injected and realized it's not in. I picked it up straight away. If I wasn't sure about the view there, I should go to another position. Because there's sometimes, as you pick it up and trying to go back in straight away, there's too much bleeding, right? So you want to pick it up and go to the other position as well. Did you see that one? Do you see that one again? I see you leaning forward. Okay, let's have another look. So inserted. Actually, it wasn't in. I refeed it. I bring it across. I go to the center, and then I load, and I make sure it's in. And I reload again, and I go and find another place I can actually visualize and double check. Right, always double check. Make sure it's in before you come out completely. So that was a reload. You could reload same place, but because of blood use, or you want to take that time to quickly find another place and fire, and then you could, let's go back and find another position. That's one way of doing it. This is another one that I placed it in. I thought, yep, that looks good. Placed my second one, and I was checking, and look what happened. Oh, actually, it wasn't in. So I had to come back, grab my trocar, pick it up again, and now I need to find another place. So I go either to the right or left. I want to space it out, so I go a little bit further to the left, and then I double check it's in. Right. So that one initially, I looked at it, oh, it looks like it's in. So hence the importance of rechecking that. And you can see the space of this compared to the earlier cases I have done is completely different. So I tell my younger self, do better. Now, case studies. This is the first one of the earlier cases a few years ago. So 77-year-old Caucasian man, in Australia we have optometrists. I don't know about in Hong Kong, do you have optometrists here as well? Yeah. So those are my referral bases, optometrists. Refer for irritable eyes. I was really bad when he first came in. Rosacea, red eye, and I see that a lot, sun damage in Australia. Pressure was up, he has severe dry eyes. Not only that, systemically he was quite unwell. So COPD, he couldn't breathe very well, he walked in with a walker, poor mobility, heart disease, sleep apnea, and dementia. So his pressure was up about 30, 35. He's got cataracts, and his discs are already cut. And this, unfortunately, this is at presentation. And it's very sad to see at this day and age where there's help, patient can still present relatively late. So one eye, as you can see, the field is already quite damaged, and the other one's not much better either. So he started with some drops. We have preservative-free, the Matafrost, and then he tried out for various reasons because of his lungs. He can't use beta blockers, and he tried those. We did get the pressure down, but then he can come back for a few months, and he said, look, his wife said he can't take it, he hates it, so he pushed it away, and they stopped the drops. What would you do if that's your case? If you don't have MIGS, what would you do? So he's now, he's systemically unwell, and you know the field's not great, doesn't want to take eye drops. You might consider laser maybe early on, because the anaesthetists don't want to put him to sleep or sedate him, but it's not a really good long-term solution. So because I had access to obviously MIGS and he's going for cataract surgery, I thought, well, let's do a combined surgery. And the pressure came down to 9 without medications early on. Considering he started about 30 to 35. And then he disappeared. So sometimes, unfortunately, some of these patients, compliance is an issue, which also means they don't come back either. They don't like seeing you, because what I'm going to do is give you more things to do. He came back 3 years later, pressure was still 12. It wasn't 9, 8. But I thought, well, that's not a bad result. His eyes, you can see, is much, much better. And he's comfortable, the wife is also happy, right? So happy wife, happy life, right? So for me, that was a good outcome. Next one, a 23-year-old. That's my other challenge, is young patients. He was a tradie. Do you know what a tradie is? In Australia, we call tradies like carpenters, construction, they work in managing construction, etc. Chris was 42 to 44, completely asymptomatic, has a family history, open angles but no secondary open angle, has asthma, Vision's pretty good, CCT is not bad. Yeah, OCT is not too bad. Feels not too bad. Says, well, why I'm doing here? I'm good. I don't need to see you. Obviously, he's got some early changes. So his Joe aging, initially avoided because they've got asthma. We did start him on some preservative-free drops. He got massive compliance issues. Pressure will go up and down. So we did convince him to SLT. Pressure did come down a little bit. 22, 24 from 40 is not too bad. But then he crept up again, he went on to drops, lost the follow-up, came back. 4 years later, he showed up. He's got his first visual field defect, on and off, compliance. And his OCT is not too bad, but maybe just some decline. And now he's getting married. He's in a relationship, and she said, "I need you to sort your eyes out." And his pressure at the moment, he's now on 4 different drops. Pressure's in the 29, 30s. I'm not entirely convinced he was taking his drops either. So it's this catch-22 situation where you want to give it to him, he's like, causes pain, and you think, I need to do something. Because otherwise, he's young, but he's already showed his first defect. So this is not him, it's just an iStent Infinite. And I was part of the 3-stent trial, so we had early access. So again, this is another microscope that we have. It's a Leica, and you need to rotate the lens, help the eyepiece, and you can see I use the same prism. There you place the first stent as far as possible. I usually do the outer, I don't do the center, I do the outer first, and then I do the central. I double check before I rotate the microscope, and I go for the third stent. So this is obviously not him because he's phakic, this is just a pseudo-phakic patient. So you can see again the vessels before and after. The plunging tells me that this is actually working for this patient. So for him, on day 1, pressures came down to 86 without any medication. That's from based on about 40 and like 30 something with drops. There's lots of follow-up. He went away traveling. He eventually did come back, and his now pressure's 12 on brizonamide. So a single drop, and he can tolerate very well. Eyes are white, he's comfortable in stable field now of those in INFL. So for him, it was a good outcome considering where he started. Next case, a 48-year-old IT consultant. He was very interesting. So he wasn't really diagnosed, but he's a really, really big, tall guy, big guy. And he said, look, I need to lose weight. So he went on a program and started going to the gym. He likes basketball because of his height. He noticed that he plays basketball on a Friday. Every Saturday he gets a headache, and his eyes will ache for about 24 hours after exercise. So he came in, was diagnosed with pigmentary dispersion. He had all the characteristics. He's already got some changes in one eye. His baseline will fluctuate depending on his exercise, so 17 to 30, and how much headache he's got. So he did try SLT. Unfortunately, it wasn't enough for him. Then he's tried almost every medication, and he just couldn't tolerate it. So I told him, look, I spend all my days on the computer. It's just really irritating and dry eyes. I don't have time to put in lubricants. And so his pressure was about 10 to 15. But he kept progressing in terms, not so much the field, but his OCT. So I started talking to him. And I said, well, tell me a bit more about what you're actually doing, like going to the gym, etc. And tell me about your fluid intake. Oh, I drink 2 liters of water. I said, okay, so how long? Oh, I go to the gym, I dehydrate. Immediately after, I put down 2 liters. I'm like, what? That's a flow overload. So I said, okay, well, let's do a water drinking test. Because I was like, every time I checked, it was like 10, 15. I'm like, that's pretty good. Why is he progressing? So he came in, water drinking test, you do about 800 mils per litre. You know, it's size, right? So he did the 2 litres. His pressure went up to almost 40. And I'm like, oh, so you're doing exercise, release the pigment, and give yourself a fluid overload. And that's why he was getting worse. So I was like, oh, solve the mystery. So his fields wasn't so bad, but his OCT, you can see, kept changing. And I thought, you're a young person, a headache, I mean, he's just miserable. What would you do? You've done the SLT, you've done this, and now it feels normal. Should I operate on these fake kids? I'm going to have a cataract, I'm not going to have surgery yet. Are you falling asleep? Anyone want to take this one? What would you do? Oh yeah, right, okay. Well, so I picked a phone to Glaukos. I said, 3-stent trial. Can I have a third stent for this gentleman? And so I actually broke my knee last year, so I was actually off work for a while. So he disappeared for a while, and he came back and he found me when I was back at work. Unfortunately, because we discussed the stents, and he was too busy and I broke my knee. So then he came back, and unfortunately during this time when I was off, he had pulmonary embolism. And then he's like, oh, now I'm on life anticoagulants. I should have done the stent before I broke my knee and beyond. Anyway, so he's now like, I said, okay, fine. Still let's do the stent, but you still stay on anticoagulants. Nothing I can do about that. So I did all my usual things that, told you beforehand. And then afterwards, obviously I didn't get it down to about, 8. I was able to get him onto Azaga, it was on like Timolol, which he can tolerate beautifully, and the pressure's now stable at 10 and 11. He said, headaches gone. I can still go to the gym, basketball, I used to get these headaches. I'm now so much happier, office service is better, I don't really have dry eyes, significant improvement in quality of life. Super happy. He wants to be my poster boy, he said. If you go to talk, tell him about me. I said, yep. Next one, 81-year-old retired GP. He's 81 but really good health. When he walks in, you look at him, he's fit. And he's been seen, obviously, before my time, over the years. And then he's allergic to a few medications, and now he's on Lumigan or Manacross and Azaga. But the pressure in the left eye just keeps fluctuating up to about 25, and he's now got quite bad dry eyes. But then you look at him and think, well, actually you've done so well. The fields all this time have been, stayed stable. Well, you know that he's progressing in terms of INFL. Now, I could leave him, but his eyes are focused and he's miserable. He said, look, I'm retired now. Finally, I'm not working long hours. I can travel, but my eyes are miserable, and I'm going to take drops with me. I don't like it. And he's already had cataract surgery a while ago. So he said, look, I don't want major surgery. I've got patients that trads. I know what it's like. Please don't do it. And feels always stable. I'm not going to trad him. Very healthy. So I expect him to have long life expectancy. But he's not maximally tolerated medical therapy. He's pseudophakic, and his con is terrible. Obviously, what would you do? You've got the answer there. With the right talk. So that's his surgery, right? And he's, not early, mild, moderate. And I went in. Now the view, I've noticed the older your patients are, the view's going to be a little bit worse because cornea is not great. So you got to practice on the good corneas before you go through these ones. So I'll do the same thing. So the 3 stents. You can see they do bleed, and highly variable how much they, often they are already on aspirin, most of the patients. And you can see I spaced it out as far as possible. Okay, and always double check at the end that you're happy with the position. So his pressure was 25 beforehand. He had SLT before was 19, and now he's down to about 23. And actually managed to stop the room again. He's on Azaga only. Pressure's about 12. He's happy. Obviously this is recent. iStent Infinite. I'm going to follow him up and see. But so far, so good. So this is another case that actually, he and I was talking about earlier, elderly patient. So I met her a few years ago. She was 90 years old. Was looked after elsewhere. And I had no history. I got no access to the notes. All I know is she's got end-stage glaucoma and probably previous ECI. You can see the scars. Probably had a trab. Iris was repaired, so you can see the proline stitch. And there was sectoral decimated chronic detachments. Cornea is not very nice. AMD without finger vision. Limbal stem cell deficiency. Poor cardiovascular health. She's not in a good place. And so she tried so many medications, really intolerant. She could only use preservative-free Manacross, but pressure was high. And then we tried TrueSoft. She immediately fainted. So the GP phoned me and said every time she used TrueSoft, she fainted. Wow, I haven't had any patients so sensitive to TrueSoft. And I think, there's not much else I could do. You're a terrible candidate for She would try, no one was to anesthetize her, right? And I'm thinking, well, what else can I do? She certainly can't have any beta blockers because of the heart. So I actually put a punctal plug in and trial that first, one eye, then the other eye, to allow her to take the truth off because she's not absorbing through a nasal, and she actually tolerated it, but the pressure was still about 20s. So then I thought, actually, well, what would you do? You got this patient, she's 90. Oh, huh?
I know, of course, iStent is an option, but just I've been thinking over those cases.
Yeah.
Other options that we also sometimes see.
I'm sure iStent would be one option, but there are also other options that we sometimes contemplate, including various lasers, or of course SLT maybe earlier on. And in those cases when we do not have to go intraocular, very often we consider micropulse cyclophotocoagulation. But if we are already going intraocular, for example, if we need to do the phaco, then sometimes we do endoscopic cyclophotocoagulation. And also, more recently, we are also considering goniotomy.
Yes.
That is also another form of trabecular meshwork bypass.
Yeah, exactly, yeah. Precisely. So, laser, yeah, and I think options, you're very experienced with laser. I've seen many of your talks, amazing talks. And access, I suppose, to the laser as well. And so certainly micropulse, gentle, recovery's fast, not in a lot of pain. Endo works well. If you are going to go for theatre, you're going to enter the eye. So she's like, no, I'm so old. She said, Judy, look, I'm so old. I don't really want to go anywhere. I don't want to trouble my family. That's the other thing. Probably like, don't trouble my family. I'm like, I don't think they should look after you. No, don't trouble my family. Can you just do bare minimum? I said, well, if I do nothing, for sure. She's AMD. She literally has nothing. She can't think it. She, like, when she walks in, she has one of the items. So we tried SLT. I couldn't believe it. It actually worked. We held her for about 2 years. She came back and she said, I'm 92. I said, yeah, but you said that when you're 90. She said, do another round. So I did another round. This time lasted maybe a year. And I'm like, okay. And then I broke my knee. So then I haven't seen her. And so then she came back. So I just thought, she said, oh, I'm now 95. Judy, I'm very old. I said, you said that 5 years ago. And now her pressure is 32. I'm like 32, 38. And I was like, wow, what else am I going to do? I mean, she tolerated eye opening, but as you know, it's temporary. I said, look, let's just buy you some time, let's talk about it. At this time, unfortunately, one of the daughters was diagnosed with end-stage cancer. So she in this dilemma, she said, I need to look after my daughter. I'm like, yeah, but if I don't do something, you can't see her. So this is a really, really horrible situation. The cornea was getting worse as she was getting older, and she said my vision's in darker. So for me, it was traumatizing. So I said, iStent Infinite came in now. Can we try? And I contacted me, just check with the physician. So can we just not even give her too much sedation, just a little bit? We do it on the topical. So we're not needing blockers. It's only one eye now. Can we just do that? So I did this only a few weeks ago. So this is her with iStent Infinite. Now you appreciate tiny little eye, period orthopathy. I could barely get the speculum in. The view is not great. Compared to earlier one. You could barely see where the TM is, and as you go, everything's depressed, and it was so small. I just got this window, so I thought, okay, I got one in. You can see it's so small, like the pelvic aperture is very narrow, it's a long term. I just thought, okay, I'll get one in, I get another view, let's get the second one in. So I managed to get one in, I thought, great, that's right in the center. And I left the worst ones to last, so I said, double check, I came out. And often I find advanced cases quite sclerosed, so you may have to redo a few times and actually place a more firm application on the TM. I refed it. There's a struggle because, she's on the topical, but as soon as I can get a view, I got that in. Now, unfortunately, the third one is where the decimator is attached, so the view's not great at the top. I did the best I could, and I just checked, and you have this tiny little window, and just see, I think we got the third one just there on the right. I got 3 stents in. Phew. Her pressure was 8 from 30 something. She was absolutely in tears. She came in, she was in tears, and unfortunately, that's when her daughter also passed away. So she was in tears and said, "You allow me to see her, and I'm going to go to her funeral." So that was very sad. It was only so I'm going to wait and see. But she said, "Thank you." You know, this is the most heartwarming case I've come across so far. There's so little we can do, and yet you can buy this in time. Last patient is a 68-year-old mixed mechanism glaucoma. She's got Myristock tooth disease. I don't know if you've seen one, but the hands are completely deformed. So the way she does it drops is 2 thumbs, like that. It's just really hard to watch her do it. She couldn't use anything. So the only thing she can use is preservative-free chromatopos is soft enough for her to kind of apply. And she hates it. She has these long lashes, and she wears glasses. Obviously no contact lenses, and so I had to become her beautician. I had to trim her lashes every time she comes in to see me, because it's just, you know, her quality of life. I mean, it's not terrible. I mean, her field's not terrible. Her OCD, you know, pretty stable, but she's just miserable. And she'll make sure you know she's miserable. So then I thought, well, IOP's not bad, the fields are stable. You know, would I offer MIGS in this case, mainly for quality of life? I'm not sure entirely a few years ago, you know, our limited experience, but now she's going to cataract surgery. So cataract is mature enough now, and she's also the sister of the director of nursing. So I'm going to be very, very, very good to her. So I spoke to her, she said, "Look, I'm really keen if you can get me off these drops." I said, "No promises." But we managed to do it, and her pressure came to about 10 to 11, no drops. She's 6'6", off, yeah, no glasses now, very, very happy. So I guess it's an unusual case, you know, it's normally, you know, if you're stable, you're probably not going to do it, but she has a special circumstance. So if you have a patient with arthritis and really can't use drops, maybe is an option. So I want to finish off talking a little bit now about when. So we talk about how, who, when. I'd like you to think about this question. Hopefully one thing you take away tonight is, if today the glaucoma surgery was as safe as the eye drops, how early would you introduce that into your practice? Quite often it's a barrier because it's cost, safety, but if it is as safe as eye drops, or maybe cost is not an issue, you know, how early would you use that? So ideal timing concerning real life, because, you know, cost is an issue. Early intervention stage will be, you know, a good point before significant complication occurs. Obviously, the patient undergoing cataract surgery is a great opportunity to do so. All when medications are poorly tolerated and the patient is non-compliant, that we talked about before, and they're not suitable for bleb-based surgery. Perhaps those are the times that we can think about this as an option. But don't miss that opportunity. So in summary, the way I think about it is similar to cardiovascular disease. And maybe the way I speak to the patients and the way that they can understand it is where MIGS fits in. So many years ago, if you have a heart attack or a blockage of your vessels, you offer open heart surgery. And that's high risk, end up in ICU. There's a risk of death, obviously. But if it's successful, you might be symptom-free for many years. Or you can take medications. But somewhere along the line, the coronary stent came in, where you could be a day surgery, right? So if you, I'm sure you know somebody in your life who's had coronary stents put in. It's a day procedure. They go home fairly soon, they're back to normal life. It doesn't last you 30 years, but it does buy you quality of life maybe 5 years, maybe more. So this is where MIGS fits into our surgical, or our surgical decision or treatment option. And I like to encourage you to think about quality of life. And this case stuck in my mind for many, many years. And you know, your patient influence what you do. So this is a gentleman who's in his 70s. He's a bus driver for life. He loves bus driving, and he actually lives on the bus. And he's still driving. So he drives a bus of a high school. So he takes these high school kids in Australia, we're a very, very big country, in remote towns, and he picks up all his kids and they go to school. That was his field when he came in. And he wouldn't let his daughter come in. His daughter dragged him in to see me. He didn't want to come in, kicking and screaming. And I remember it so well. It was the most horrible thing to say to someone who loves bus driving. You can't drive. You can't even drive a normal car, let alone a bus of kids. I had to call his daughter in. I feel threatened. I think it was going to hit me because it was like, you just took my life. I just saw the devastation. I mean, obviously he's devastated with what we discussed, but I was kind of part of that algorithm. So I brought her in and just had to give the story to her as well to stop him from driving. And they stuck in my mind that if he had come in and wasn't so scared, even 10 years ago, maybe I could have helped him. And so now I'm determined to get to these patients before they get to this stage. So then it leads to this, early on, the 2025 treatment paradigm. Everybody have their own paradigm, but maybe after discussion, you can shift your paradigm. Doesn't have to fit this one, but maybe consider it and think about it. So in summary, best of MIGS candidates, especially if you're starting out, open angle, minimal KS. Your baseline is not too, so high baseline, but your target is not too low. These are good candidates. Mild to moderate open angle glaucoma, ocular hypertension, secondary open angle glaucomas, and if the patient is motivated to reduce the drop burden. However, you can use this, but with caution. Advanced glaucoma with very low target IOPs, patients with extensive phakic closure or PAS, and definitely no to patients with secondary glaucomas with poor alpha pathways. There's definitely a role for traditional surgery. So to have a balanced view, we know that tubes and tracks still have the longest follow-up data. And skill in this area is still very important, especially in our current society, especially those uveitic patients. So it's really important that younger generation still gets a chance to learn traditional surgery and well-trained in these areas. Otherwise, we may end up with only a few people who can do it. This is happening in all specialties, as we evolve and change. So we need to ensure certain skill sets are passed on. And I think we still have enough patients, unfortunately, where we can still do that. However, hopefully we can still also train them in these new technologies so they can advance this area as well. So I'll leave you with this Albert Einstein quote. We learn from yesterday, live for today, we hope for tomorrow. But the most important thing is not to stop questioning. And that's how we advance in all fields of life, and hopefully glaucoma as well. Now I'm from Brisbane. Compared to your city, we have a long way to go. However, we do have the Olympics coming up in 2032. And hopefully I'll see more of you coming to our side of the world and share your experience with us. So thank you.